So for my last abstract, which will present sort of outcomes in patients 70 and older enrolled into BMT CTN 1703, really the concern or question in hand is certainly we've seen reduction in significant GvHD with the use of post-transplant cyclophosphamide. We've also seen sort of sustained toxicity giving this approach in patients overall. So for an older population, which generally tends to have higher rates of treatment-related toxicity, our question was whether PTCy in this older population would sustain a benefit overall. And so we looked at patients who were 70 and older who enrolled into BMT CTN 1703, which again was a study comparing post-transplant cyclophosphamide to Tacrolimus methotrexate as GvHD prophylaxis. Overall, 96 patients of the total cohort were 70 and older. We examined these patients. We had an even split, so an equal proportion received either POSI or methotrexate. And what we found in this study was, again, post-transplant cyclophosphamide resulted in a significant reduction in 1-year GvHD-free, relapse-free survival. Furthermore, what was different than the overall analysis was that when we looked at overall survival, we saw a significant improvement in overall survival in these older patients who were enrolled into the post-Cy cohort. So 1-year overall survival was estimated at 90.6% compared to 61% with TAC methotrexate. Just to give context, what has been reported in this patient population up until this point was that the treatment-related mortality at 1 year for this patient population is around 20%. So this represents actually a pretty significant improvement compared to historical outcomes in terms of 1-year survival in this older population. So looking at sort of other parameters of interest, when we looked at patients treated with post-Cy, they had a higher probability of being completely off systemic immune suppression by 1 year. So 60% of patients at 1 year were systemic immune suppression free versus 38.8% with TAC methotrexate. We also did not see any increase in significant infections between patients treated with post-Cy or TAC methotrexate. So overall rates of grade 2-3 infections were around 23 and 25% for these populations. Finally, we didn't see any increase in organ toxicity with either use of post-Cy or TAC methotrexate. So we did see toxicities in both groups. So 30% of patients had a significant cardiac toxicity with post-Cy, but also 34% had significant cardiac toxicity when undergoing transplant with TAC methotrexate. These toxicities in terms of liver toxicity, kidney toxicity, and thoracic or lung toxicity were equivalent between the two arms as well, really indicating that post-Cy potentially does not increase the toxicity, nor does it lower toxicity in patients who are undergoing transplant. So the conclusion really for this analysis is that post-Cy maintains a GvHD protective effect in older patients, patients 70 and older, does not add to toxicity compared to standard prophylaxis with TAC methotrexate, and should also be considered to be standard GvHD prophylaxis in the 70 and older population, particularly in light of the very encouraging sort of 1-year survival amongst patients who are 70 and older enrolled into the PTCy arm.